Okay, so I'll be talking about, so it's mainly MPN JAK inhibitors and versus new pathway inhibitors and when to switch therapy as a clinical guide. So this is our outline, compare efficacy and safety of JAK2 inhibitors in myelofibrosis and also in MPNs, review emerging non-JAK pathway inhibitors, and define practical triggers and clinical algorithm for switching therapy. So where do we stand today? I mean, modern diagnosis integrates morphology with rigorous genetic testing, moving beyond clinical suspicion to a molecularly defined entities. Disease spectrum encompasses the ET, PV, and the myelofibrosis, both primary and secondary, and it's characterized by clonal hematopoiesis with highly inflammatory marrow environment. The clinical burden, the patients have a lot of challenges, including constitutional symptoms, progressive splenomegaly, and risk of thrombosis and severe cytopenias. Now we're depending more on NGS panels and finding high molecular or high risk molecular risks mutation, which significantly impacts the overall survival. As you see here, this is the driver mutations and other co-mutations that we could see. The current treatment landscape for ATMPV, they're still focusing mainly on thrombosis risk reduction. And standard of care includes phlebotomy, hydroxyurea, and interferon. For myelofibrosis, still transplant is the cornerstone of treatment. Treatment, and they're using for a cure rate, and they're using JAK inhibitors is the cornerstone for spleen reduction and symptom control. There are a lot of major unmet needs that we will discuss, but there are largely palliative, not curative, other than the transplant. And there are key gaps, including lack of true disease modification. So here we'll talk a few slides about the JAK inhibitors. So here are the approved agents. We have the ruxolitinib, which works mainly on the JAK1, JAK2. We have the fedratinib that spares the JAK1 and mainly works on the JAK2 and has a different also line of treatment, which is the FLT3 inhibition. We have the pacritinib, and mainly in severe thrombocytopenia patient also spares JAK2. And we have the mimalotinib with, other than targeting JAK1 and 2, also it has an ACVR1 blockage. This is them, the drugs side by side, and we'll go over them, the major trials very quickly. So first one is ruxolitinib, Jakavi. This is the pivotal trial is Comfort-1 trial that tested ruxolitinib versus placebo, and the primary endpoint was met, which they used the spleen volume reduction by 35%, and it was met at 41% versus nil almost in placebo. They also used the total scoring system of reduction of symptoms by 50% response. And this is, they check the burden of the disease by fatigue, early satiety, and also abdominal pain. And there was a response of 45%. And it had a significant symptom burden reduction. Then they tested it against the best available therapy and in the Comfort-2 trial. And here still it had good results. And it had long-term follow-up, confirmed sustained spleen response and survival advantage. The major side effects, anemia, thrombocytopenia, neutropenia, and there's an increased infection risk and long-term risk of non-melanomas skin cancer. Still, but it's not disease defining. It doesn't affect the burden of the disease. We have fedratinib, and it was tested in the Jakarta trial. This was in patients who are JAK naive, and still it met the primary endpoint of 36 to 40% reduction of the spleen, and also the symptom total scoring system was also met, and was an effective first-line option. Then it was tested in the post-ruxolitinib trial, period, mainly in refractory or relapsed patient, and there was demonstrated efficacy in patients resistant or intolerant to ruxolitinib. These are the adverse events. There was a lot of GI symptoms and also anemia. There's a boxed warning. Wernicke is encephalopathy, so we should monitor thiamine levels before and during the treatment. Pacritinib, helped because a lot of these patients, they start with low platelets anyway because of the myelofibrosis of the bone marrow. So here they tested in PERSIST-1 trial and PERSIST-2. And in PERSIST-1, it was against the best available therapy. They didn't put a platelet cutoff, but it was effective regardless of platelet count. And also it met the spleen reduction, consistent spleen reduction across all the subgroups. PERSIST trial, here they put a cutoff point for platelets less than 100, and it showed good efficacy also. So the most common non-hematological side effects, again, there is gastrointestinal and also there's cardiac events. So bleeding risk, we need to monitor coagulation, and also there's a cardiac toxicity with prolonged QT prolongation. Momelotinib was also a savior because a lot of patients have anemia to start with, and it was tested in the Momentum trial. And here it was tested initially against danazol, and also it met the scoring system for pain, for symptoms reduction, and also for reduction of the spleen, and it had a sustained efficacy over time. It has a unique mechanism of, other than the JAK2 inhibition, which is the ACVR inhibitory effect. By this, it lowers the hepcidin levels, increases iron availability for erythropoiesis. And this really distinctively addresses anemia of chronic inflammation. It was then tested against ruxolitinib for spleen response, and it was non-inferior, but it was superior for transfusion independence. Adverse events as listed here. Still, we have a lot of 4 approved, but there are still limitations of the JAK2 inhibitors. One is the biological limitation. It doesn't eliminate the malignant clone, so you're not really curing the disease. It's more of a palliative therapy. And also the durability and resistance. It's acquired resistance. A lot of patients within 3 years, 50% of the patient will lose or discontinue ruxolitinib within 3 years due to loss of response, and also due to suboptimal responses where the spleen stops. There will be no reduction of the spleen size further down. There's the toxicity profile, those limiting cytopenias, and also the infection risks, like we said, the reactivation of herpes zoster and the TB and opportunistic infections. There is secondary malignancies, especially the skin cancer, and needs a lot of follow-up. Also, the clinical endpoint has been debated and challenged that the surrogate markers that we're using is not representative, especially using the spleen volume reduction or using symptom control versus overall survival. And sometimes it's really disconnected with a real life. I mean, the spleen response does not always correlate with leukemia, transformation risk, or the fibrosis involvement. So we need more new endpoints like molecular remission, fibrosis resolution, and event-free survivals. The second section is the possible pathways to target beyond the JAK2 inhibition. So here we have a lot of immune dysregulation in myelofibrosis or MPN. As you see here on the right, primary myelofibrosis, polycythemia, and essential thrombocythemia, a lot of cytokine. This looks like a cytokine storm there. The elevated levels of pro-inflammatory cytokines are predictors of inferior survival and leukemia transformation. These could be therapeutic implication and targets. So we have fibrosis drivers and marrow remodeling. So targeting this will reduce the collagen deposition and fibrosis. There is neutrophilic constant or chronic neutrophilic inflammation and what they call neutrophilic extracellular traps, which plays a role in fueling thrombosis and inflammation, and also reversing immune exhaustion and structural modulation. Here are some of the emerging pathways. I'm talking about mainly about the phase 3 or phase 2 trials. So you have the BET inhibition, pelabresib, which targets promethazine and extraterminal proteins, and we'll have a slide about that, and also BC2 inhibition, navitoclax. So for the first one, BET inhibition, I mean, it inhibits this protein, BET proteins. This blockade will stop the pathway of NF-kappa signaling. This will reduce inflammation of the inflammatory cytokines and inhibits JAK2 and STAT5 target genes, which will address the root cause of fibrosis. It was tested in the Manifest 2 phase 3 trial, and it had the same, it met the endpoint of spleen reduction and the symptom scoring system reduction, and also anemia and the hemoglobin improvement and reduced transfusion burden, and most importantly, the mainstay of this disease, which is fibrosis, and there was more than 1 grade reduction which was significant. This is the safety issue, again, thrombocytopenia, anemia, and GI toxicity. So it could be considered for JAK-naive patients with high system burden, but it needs a lot of monitoring. The second one, which is BCL2 family inhibition, and that's navitoclax. It inhibits BCL2 and releases pro-apoptotic factors, which induces apoptosis in the malignant clones. And this was also tested in the phase 3 trial Transform 1, and still it met the primary endpoints of spleen reduction and also the symptoms. Also, there was response in the fibrosis reduction, and there was also disease modification, and JAK2 burden was reduced. Side effects are there, and it could be a target patients suboptimal responders to ruxolitinib that have adequate platelet counts, because thrombocytopenia is a major issue. And it could be a strategy of an add-on to deepen the spleen and symptom response without switching the backbone therapy. Here is another pathway. This is all investigational. We have the MDM2 inhibition and the XPO inhibition. So for the MDM2, there is naftamadlin, and it disrupts the p53 interaction. So this will restore the p53 tumor suppression function, and so it offers a novel mechanism to target malignant clones and overcome the JAK inhibitor resistance. This was also tested in 2 trials, the phase 2 Boreas and also the phase 3 Poiesis. And it showed, and it was tested in the relapsed or refractory myelofibrosis patients, and also with a combo with Rux. And still, it showed good results. The Poiesis is still ongoing and should be reported within this year. And there was 48% of the evaluable patients, and the Boreas showed bone marrow fibrosis reduction. This wasn't a target before, but now we see it more with the new drugs that we see this fibrosis reduction. Again, here for the XPO selinexor, and also it induces growth arrest and apoptosis. And also it was tested and it had good responses, but these are still early trials. Here, the famous drug in here, this is the antifibrotic pathways. The famous one is the one on the right, is luspatercept, which we are using in thalassemias and myelodysplasia. So it's targeting anemia and myelofibrosis, and it promotes terminal differentiation of late-stage erythroblasts. So it rescues the cells from apoptosis caused by the ineffective erythropoiesis. And it's approved for MDS, especially with the ring sideroblast, and growing evidence, especially in patients with the ring myelofibrosis with the ring sideroblast, or who have the SF3B1 mutation. So ideal candidates are transfusion dependent, low hemoglobin, and it could be as a combination strategy. Still more studies here. We're going to skip this. The only one we'll talk about is emerging telomerase shortening, imetelstat. And here, competitively, it inhibits telomerase enzyme, and the MPN cells have elevated telomerase activity and shorter telomeres, so it could be a target. And it was tested in the IMPACT MF phase 2 trial, and it had a survival benefit. So complete remission was 10%, overall response was 30%, and there was a median overall survival of 21 months compared to historical controls. There was a molecular response and a good symptom control. Here, the last part of the talk went to switch therapy. So here we have to define treatment failure versus suboptimal response. Treatment failure is mainly, and this is in this point, switch is mandatory. So we have progressive splenomegaly, worsening symptoms, intolerable adverse effects, blast progression, and transfusion independence. Suboptimal response here, you consider switch, or you could put an add-on medication, and this is mainly an insufficient spleen reduction, partial symptom relief, dose limiting, cytopenia, or persistence leukocytosis. So here an algorithm, we should optimize current therapy before switching, adherence, confirmation, max tolerated dose is reached, and 3 to 6 months of trial duration and no reversible causes for failure. Then we go to profiling the failure pattern, which is it a problem with the counts? Is it a spleen size, or is it the symptoms? And then depending on your phenotype, you could select your next line or the first line. So if you're having anemia predominant, you could go with the mimalotinib, severe thrombocytopenia, pacritinib. If there's retux failure or intolerance, you go with the fedratinib. Here is sequential therapy strategies. You could go from rux to fedratinib in case there is failure or intolerance. You could go from rux to pacritinib if you're with severe thrombocytopenia. Any JAK2, you could switch to momelotinib if you have severe anemia. For supportive and add-on strategies, you could add on especially luspatercept, especially for transfusion-dependent patient as an add-on. This is some of the combination therapy approaches. It's mainly for to deepen the response. So you could add the liprecept to ruxolitinib, again, navitoclax to ruxolitinib, especially if you have good platelet count. And as we said, the luspatercept for spleen size and anemia. On the right side, this is mainly investigationals, but these are possibilities. This is just a small case. You have a patient who's on rux. He has a big spleen, which is progressive. Symptoms worsening, platelets, hemoglobin, and here you could switch to pacritinib for the platelets, add luspatercept for the anemia. This is some of the algorithms, just for the sake of time. So the clinical pearls and monitoring. So baseline assessment and prophylaxis. Mandatory thiamine B check before fedratinib due to Wernicke's encephalopathy risk. Herpes zoster prophylaxis recommended. And annual skin surveillance for non-melanoma skin cancer is essential. Dosing strategy, start low, go slow in cytopenic patients, but aim for the maximum tolerated dose. Suboptimal dosing is a frequent cause of perceived treatment failure, and this will burn our bridges in treatment therapy. Response tracking every 12 to 24 months following the spleen reduction, volume reduction, and the symptom scoring system, and watch for switching signals. Summary, JAK inhibitors remain the cornerstone. First line selection is driven by cytopenia profile and symptom burden. Novel pathway shows promise, not really ready for the prime time or the takeover from JAK2 inhibitors from the beginning. Define the failure early and prioritize clinical trials. So our future direction is combination strategies, which is moving toward ruxolitinib plus X upfront to by any of those new drugs. Precision medicine there's more information about the CALR mutant specific therapies and vaccine antibodies, and endpoint evolution of shifting from spleen and symptoms only to fibrosis reversal and overall survival. And the goal is to transform MPN from chronic management to disease modification. Thank you very much.